All right, good morning, good afternoon, and good evening to everyone joining us from around the world. My name is Stephanie Levy. I'm a Senior Technical Advisor for Social and Behavior Change at the U.S. Agency for International Development. It is my pleasure to welcome you to the third webinar in the Breakthrough Action Learning Series, From Insight to Impact, Leveraging SBC for Sustainable Change. Next slide. This 5-part series is designed to showcase the transformative power of social and behavior change, or SBC. Through these webinars, Breakthrough Action aims to inspire, inform, and encourage you to adapt these proven approaches to your own contexts. Next slide. Today's session, Leveraging SBC to Strengthen Health Systems, highlights how SBC tools and frameworks, such as the Provider Behavior Ecosystem Map, are driving meaningful improvements in health systems across different contexts. We'll learn how SBC strategies are being applied to address systemic challenges, from compassionate care in maternal and child health to service delivery bottlenecks in malaria programs. We are thrilled to have 3 distinguished presentations today. First, Heather Hancock, Senior Program Officer with Breakthrough Action, will introduce the Provider Behavior Ecosystem Map. This tool helps stakeholders understand the multi-level factors influencing health providers and design interventions that holistically strengthen health systems. Next, Dr. Sunday Domenico, National Maternal and Perinatal Death Surveillance and Response Focal Person at the Ministry of Health in Tanzania and the President-elect of the Association of Tanzania OBGYNs, and Juliet Sizia, Maternal, Newborn, and Child Health Advisor with Breakthrough Action Tanzania, will discuss a compassionate, focused intervention for improving maternal and child healthcare experiences, emphasizing the importance of respectful and empathetic care for clients and creating a supportive workplace environment for providers. Third, Augustin Ngandu Ulong, Malaria SBC Advisor with Breakthrough Action DRC, will share lessons from testing a malaria service delivery tool that applies a behavioral lens to identify challenges and actionable solutions for improving adherence to clinical guidelines. This work and this presentation were developed with Dr. Piki Mbayo, National Malaria Control Program Data Manager of the Democratic Republic of Congo, who unfortunately cannot join us today. These presentations showcase the unique value of SBC in addressing health system challenges, empowering providers and other actors within the health system, and ensuring better health outcomes for clients. Next slide. Before we dive into the presentations, a few quick housekeeping items. This session will last approximately 60 minutes and includes a Q&A segment. You can submit your questions anytime using the Q&A feature, and we'll address as many as possible during the session. Simultaneous French interpretation is available. Please click on the interpretation icon at the bottom of your screen to select your preferred language. Slide, please. So without further ado, let's begin with our first presentation on the Provider Behavior Ecosystem Map. Heather, over to you.
Thank you, Stephanie. Good morning and good afternoon. I am really happy to be here today to share the Provider Behavior Ecosystem Map, which was born out of a desire to strengthen health systems and improve quality of care. And we know that health systems are complex, but at their core, they're about people. And as we started to unpack some of that complexity, we chose to focus on providers and consider how we could create a more supportive ecosystem for them. Next slide. We chose to focus on providers because they are critical actors in the health system, especially given their close and frequent interactions with clients. We know that the decisions and actions providers make impact the performance of the health system overall and the health of communities. And their behavior also impacts the behavior of clients, including care seeking and the adoption and maintenance of products or behaviors. And what's more, we know that there is a bidirectional relationship. The health system also impacts providers and their behaviors. Health system actors, including providers, are people. They're human beings who have barriers and facilitators to their behaviors. Next slide. There has been a lot of great work with providers over the years, so why take an ecosystem approach this time? Providers operate in complex systems that both directly and indirectly impact who they are and how they act. And if we truly want to strengthen health systems and improve the quality of care, we need to fix systems, not simply expect providers to be better. Providers are whole people whose behavior is influenced by many factors at multiple levels, and many of those are outside of their direct control. And so responding to this reality requires us to apply a systems lens to the design and implementation of provider-related initiatives. And it's not enough just to train providers or incentivize them or supervise them. In order to deliver high quality and respectful care, providers need the system where they operate to enable and support the behaviors that improve provision of care. Next slide. As a thinking tool, the provider behavior ecosystem map allows us to examine the wide-ranging factors that can shape and influence facility-based provider behavior, and also observe the interactions and connections between those factors, and consider different approaches and strategies that may be needed to address these factors across the ecosystem, and ultimately design and implement more effective, supportive provider behavior change initiatives. Next slide. The map visually represents the provider's ecosystem, showing the need to better support providers, not blame them, by addressing the factors that influence them, including, but not limited to, provider-side factors. And there are many great quality improvement initiatives and tools, and this map complements those existing approaches and provides a unique social and behavioral lens. Many provider-focused initiatives have neglected the opportunity to explore and address the broader system and variety of factors influencing provider behavior. This map facilitates systems thinking and planning by showing factors across the ecosystem and their interactions, highlighting how a variety of approaches and strategies across different partners will be needed to adequately support providers. Next. The provider behavior ecosystem map was developed using a rigorous co-design process, starting with a literature review to identify influence factors, and then ground truthed through interviews with providers in 9 different countries. We also held an expert consultation and co-design sessions, and then tested it with stakeholders around the world. Next. And the resulting product is an interactive map that visually displays the complex system where facility-based providers operate. It is organized around the provider at the center, and it includes key actors and entities, influence factors, component groupings, and components. And I'll talk about each of these in more detail. Next slide. In the center of the map are the actors, or individuals and groups, and entities, or organizations and institutions, that interact with providers across the system. And you will notice that the actors and entities are placed at different levels where they operate, including the individual, interpersonal, community, organizational, or public policy levels. And the actors and entities are color-coded to align with the influence factor that they are primarily associated with. Next. As I mentioned, the map is interactive, so when you click on the key actors and entities in the center of the map, a pop-up window will appear with a description of the actor or entity and how it can impact provider behavior. In the example here, we have religious institutions and how they influence providers, community members, and clients' attitudes and beliefs, as well as the broader sociocultural norms and even policies that then trickle down to providers. Next. The map is influenced according to influence factors, which you can see in the innermost ring with the multicolored blocks. These influence factors are the overarching groupings of elements that interact with one another and influence provider behavior. You can see the 7 influence factors are the individual provider, the provider's personal relationships, the client, community context and social norms, workplace environment, health system governance, and country and geopolitical context. Next. Again, when you click on an influence factor, you will see a description of the factor and how it affects providers. Here we have an example of the workplace environment factor and how its people, culture, and governance can influence how providers offer services. Next slide. Each influence factor then divides into component groupings, which then further divide into components. Component groupings and components are the more specific elements that can affect provider behavior in any given environment. In this example here, we have the health system governance influence factor, and you can see the individual components in each of the three groupings that influence providers, such as career advancement, health system policies, resource management, and provider support structures. Next. These influence factors and components interact with and connect with each other because they are all part of a system. And these interactions and connections are called interrelationships. When you click on a component, other components will light up around the map, showing you those connections. In the example here, you can see how hierarchy and power dynamics in the workplace environment factor influence a provider's sense of perceived autonomy and the processes and procedures in a facility, and are influenced by the larger health system culture and community and gender norms. Next slide. I'd like to highlight a few examples of factors at some levels of the ecosystem. So starting at the individual level, a provider's real and perceived identity, including their demographic characteristics, the roles that they play at home and in the community, and their beliefs, can all affect their behavior. A provider's sense of their identity can condition how they view themselves and others, how they interact with others, how clients or colleagues view them, as well as how well they relate to others and their biases overall. Next slide. At the client level, the degree of agency and power that a client has can influence their decision-making and health-seeking behavior and their interactions with providers. This, in turn, can influence the client-provider relationship, the provider accountability, and client willingness and ability to share health information, their needs, and make decisions. Next slide. At the community level, social sanctions, or the actions used to enforce social and gender norms, can affect community, client, and provider behaviors. For example, a provider may hesitate to offer family planning services to a young person because they're worried about angry parents or being reported to authorities. Social sanctions can also influence people's willingness to talk about certain topics or seek care, or a provider's willingness to provide care. Next slide. At the workplace level, processes and procedures such as client flow or intake procedures, note-taking, scheduling, or referrals can influence how providers view clients and services, provider motivation, their job satisfaction, overall facility efficiency, stress levels, and quality of interactions. Next slide. At the health system level, finally, how resources are managed and distributed influences whether providers have the tools, the supplies, and the skills that they need to provide services effectively. Resource management also impacts provider stress levels and motivation and the degree of trust that community has in the facility and health system. Next slide. The provider behavior ecosystem map has been adapted to different health areas as well as to community health workers. It has been used across diverse country contexts in various stages of program or project implementation and different service delivery settings to deepen the understanding of provider behavior. For example, it can and has been used to inform formative research priorities and highlight gaps in provider behavior data. It can also be used in project design and implementation to explore and prioritize behavioral drivers to address through provider initiatives, or as a framework to develop materials and tools. It can prompt dialogue around what behavioral factors to include in a monitoring and evaluation plan, or it can be used to advocate for broader support and additional resources for healthcare providers and provider behavior change initiatives with governments and donors. Next slide. We have also developed a suite of resources to accompany the interactive website, including a guide, a brief, instructional videos, and a brief for monitoring and evaluating provider-side initiatives using the ecosystem map. You can access all of these resources via this QR code here. Next slide. And I'd like to wrap up my presentation by encouraging all of us to put the effort into understanding providers' realities and the systems in which they operate and considering what we can better do to support them. Thank you.
Wonderful. Thank you so much, Heather, for illustrating how the provider behavior ecosystem map offers a structured approach to understanding the complex interplay of so many factors influencing health providers. The holistic perspective this tool brings is invaluable for designing supportive interventions that enable providers to deliver high quality care. Participants, please share your questions or comments in the Zoom Q&A, and we will address them later in this session. Next slide. Now, we're going to hear from Dr. Sunday and Juliet Sizia, who will share insights into enhancing maternal and child healthcare through compassion-focused interventions in Tanzania. Dr. Sunday and Juliet, the floor is yours.
Thank you very much, Heather, and thank you very much, Stephanie, for very kind introduction. Empathy and compassionate critical client experience of care are also important for providers. Evidence shows that providers practicing empathy and compassion can positively impact clients' feelings and behavior, leading to more positive clinical outcomes and a fewer complications that you also wish to see. Compassion also improves provider job satisfaction as well as self-esteem, reducing burnout, aggression, among others. While respective care has been studied, less has been centered around the experience of care in the postpartum period. And we understand that other studies done have real focused on the client experience. Next slide. As you had the presentation from Heather on the provider behavior ecosystem, it's a really interesting tool that helps you to understand and see how different factors would interact with each other, but also interact with the system in defining the provider behavior. So we worked on this model, but also learning from the local health system to see how we would design and intervene in a way to advance respective care through compassionate among the provider and the healthcare provider, healthcare and the client as well. Next. So in this process, it was a very engaging process, which involved a lot of consultations as well as implementation approaches. So we had a core design and then implemented and evaluated, and I'll be very happy to share with you some of the interesting findings from that work. So as usual, we started trying to understand, synthesizing the existing evidence, building on the existing work through a rapid desk review. And this really made us into another level where we had a lot of consultation, mostly virtual, and this was 2 years ago. And this helped us to unpack the factors that influence experience of postpartum care. And we took these findings to another level. We convened a multi-stakeholder workshop for co-designing. And this workshop was beautiful because we had the expert from all the way from the ministry level, regional councils, our partners, Uzazi Star, but most importantly, we included the community members. As you know, experience of care is a very complex phenomena. After the co-design, then now went into developing the intervention, and we refined the intervention, submitting the research protocol and monitoring evaluation plan along the way. And finally, it was now opportunity to implement the intervention that we had designed. And this was a very good partnership with Uzazi Star, as well as the Minister of Health. And interestingly, we had a very robust evaluation trying to capture and understand each and every output out of this exciting work. Next. So it was not a straightforward intervention package. We had 7 components. I think this reflects the dynamism and the complexity of experience of care, especially if you wish to address both the client and the provider experience. So first and foremost, we had some good way. Leadership is quite an important aspect. So we did leadership training on compassionate care to the managers and healthcare providers to make sure they are on the steering wheel when it comes to intervention implementation. But then after that, the second intervention was self-care practices. And these were really meant to ensure the providers would be able to understand and engage each other in ensuring mental well-being throughout the care they provide. We had a client feedback system, and this client feedback system was meant to learn how much the client were receiving care from the providers and see areas for improvement. But again, an interesting aspect of this that we also wanted to ensure we continue to motivate and encourage providers to do better. So we had the compassion champion of the month in every single facility. And this was voted by peers, but also worked on the feedback that was received from the clients. And then you're able to identify the compassionate champion, sort of to encourage others to do better. We also had a provider self-assessment that would really try to assess how much they are doing and how much they are responding to the self-care. Critically, if you want to intervene and maintain this program, we had a very robust mentorship and supervision process. And of course, the client charter. And this charter, we had adapted the local MOH charter and then customized in a very simple way, describing what are the client rights and what are the providers' responsibilities and rights in that context. Next. So you could see our theory of change that we really had introduced here. You see the two sides. We have the provider components on your left and the client component in your left. I know most of you have worked on a compassionate care. We have really focused on the client, but you see the difference here. So for the provider components, on your top to the left, you see what we did, including ways to ensure there's learning, self-care, coaching and recognition. We did issues like compassion. I mentioned about compassionate leadership training, self-care practices, mentorship and coaching, but also having compassion champion of the month, as well as self-care assessment. But also you could see down there the result, the outcome that you're expecting to see, both in the short term and long term, including the increased competence of the healthcare provider, reducing fatigue and burnout. And the long term, we wish to see how much that will improve emotional well-being and improve retention. But this was not measured in this study. So on the client aspect that you see on your right, we really invested on the feedback loop, but also the seeing how much clients are experiencing the care. And the key investment here where the client feedback system was the client service charter that I mentioned earlier. And the short-term result that we are looking forward is improved perception of the provider on compassion, but also improved perception of care. And then long-term, definitely looking how best we could increase health-seeking behavior among the client and the community at large, but also improve their health outcome that we wish to see, reducing of mortality and others, but these were not measured in the study. But what I wish also to highlight you, this experience of care was also very well matched with the community interventions to ensure that we are real at page both at the clinical settings as well as community settings. And this was led by our partner Uzazi Star Project, which was a key ally in this important work. So at this point, please set your ears ready. I want to invite my colleague Juliet. We'll talk a bit about the objective, how we approached, and some high-level findings from the study. Thank you. Juliet, next.
Okay. Thanks, Dr. Sunday. Our research objective was to assess whether our interventions improve the experience of care for client and whether provider changes also occurred. We focused on examining compassion in particular. Next slide. As Dr. Sunday mentioned above, we selected factors from the provider ecosystem on the left that were most influential and designed the intervention around them. We studied changes in both client outcome focused on a perception of care and providers outcome ranging from use of compassion to their job satisfaction and the resilience, as you can see. Next slide. We started with a short 2-month pre-test to see how the intervention component that Dr. Sandy described earlier were working. We then did a mean evaluation by interviewing both the providers and the client and use that data to refine the intervention further. Then we conduct the baseline survey carried out to the intervention for 6 months and conduct an end-line survey just last month. We had 3 intervention facilities and 3 control sites. Next slide. We reviewed measures by examining validated scale shared through the WHO compassion rounds, reviewing MCGL measures, and many more. Here is a list of those we considered. We selected those that were feasible to use and most related to our study objectives. I won't go through them, but we will share the slides after in case you want to look into them further. Next slide. Okay, here is a list of 3 intervention and control facilities in Mwanza. All are supported by the USAID funded Uzazi Star project. We included a mix of low and high volume sites with dispensaries, health center, and hospitals to see how the intervention performed at different levels. Next slide. Well, we just completed the end-line data collection and are still conducting analysis. The result the result I'm presenting today is just a preliminary. When looking at the effects for providers, we assess changes using a standardized globally test index. When looking at a provider perception of their skills, 3 components improved significantly in intervention facilities include: 1, being supportive when talking to the patients; 2, speaking to patient with kindness; and 3, see things from their patient perspective. When it comes to the provider burnout, 9 components improved significantly for the providers in the intervention facility. I won't go through them all, but you can see improvement in finding their work full of meaning and purpose, such as feeling enthusiastic about their job or feeling resilience mentally. Next slide. When it comes to the perception of organizational support from their health facility, providers were asked their level of agreement with 17 components. Intervention facility reported a significant increase in their perception of support available from the facilities when they have a problem or that the facility really cares about their well-being among others listed. Further, 100% of providers believe the intervention was culturally acceptable and appropriate, and 92% wanted to continue with the intervention. Next slide. Look at the changes among clients. We see improvement among providers appear to have led to improvement in experience of care for clients. 360 clients were interviewed in total, half on baseline and half on endline. At endline, the control facility had not changed significantly. In contrast, clients who visited the intervention facilities at the end line reported a vastly improvement experience of care compared to the baseline. These results were highly statistically significant across every one of the 10 components of the scale you see on the slide. For example, Clients thought their providers expressed sensitivity, caring, and compassion for them, tried to understand their emotional need, and gain their trust. Next slide. The analysis of end-line data is still underway. However, these initial results are encouraging. Providers in the intervention facilities show significant improvement around burnout and support from their health facility. Importantly, client-reported experience of care improved significantly. Our next step are to finish the analysis and then share the complete findings with stakeholders in Tanzania to see if the intervention may be applied either way or scaled. Finally, we will work on the manuscript for peer review. Next slide. Finally, we want to acknowledge the incredible partnership with so many actors in Tanzania listed here, including USAID and the Users Star project for truly cooperative efforts. And here, again, is a link to the tool and the resource for more information. Thank you, and back to you, Stephanie.
Wonderful. Thank you so much, Dr. Sunday and Juliet, for highlighting the transformative impact of compassion-focused interventions on both client and provider experiences. It's inspiring to see how these tools are being used to address challenges and foster more compassion within healthcare settings. The preliminary evaluation results are very interesting and promising, and I look forward to seeing the final results when they are ready. Again, for our webinar attendees, if you have questions, please submit them in the Zoom Q&A. Next slide. Lastly, we'll hear from Augustin Ngandu, who will present findings from testing a tool for malaria service delivery in the Democratic Republic of Congo. Augustin, over to you.
Ok, merci Stéphanie pour la parole. Bonjour à tout le monde. Nous présentons
Hello,
au nom
thank
du
you
groupe
very much, everyone.
participer au développement et au pré-test de l'outil d'analyse, donc des
We did
services,
this
la lutte contre
pre-test
le
on
paludisme et nous sommes
to
très
get some
ravis de
analysis,
partager l'expérience de
and
la
we are
RDC.
happy to share with you the
Next
experience of the RC. Next one, please.
Les équipes sanitaires ou des zones de santé, les partenaires de mise en œuvre,
And
font
district
toujours
health
face
teams and
à
implementing
plusieurs
partners
problèmes potentiels
frequently
liés
hear
à l'offre
about
de
potential
services.
service delivery
Et ces
concerns in
problèmes
specific
sont
health facilities.
identifiés
These
lors de la
concerns are
supervision,
identified
lors
when
des
we do some
réunions
field
d'analyse
visits,
mensuelle des
when
données
we
dans
have
les établissements de
communications,
soins.
monthly communications with the
Mais ces
facility
concerns
staff,
sont complexes,
but
d'où la
the
nécessité de
concerns are
l'approche
complex.
comportementale
And that's why
pour
we need to
analyser de
use
façon
the behavior
Face à ces
system.
problèmes, Breakthrough Action a développé un outil
Breakthrough
qui
Action
va
developed a
adresser
comprehensive
ces
tool
problèmes
to be able to assess this
indispensables
problem better,
pour la lutte
to
contre
help
le
national
paludisme
malaria
à
programs,
travers le
district
programme
health teams, and
national de
implementing partners
PNLP en
respond to
RDC
signals
et
of service
du cadre
delivery
des zones de
challenges.
santé. L'outil qui a été conçu
This
conjointement
tool
ici a
that was
servi
created
vraiment
here
à analyser les données, mais en complément des outils
analyzes and collects
et
data
remplacer ce qui était sur terrain. Next slide.
so that we're able to understand this issue better. Next one,
Le
please.
processus, à travers cet outil, permet vraiment
The
aux
process
prestataires
using these
des zones de
tools
santé ou des districts à prioriser les principales causes des problèmes liés à l'offre de
helps to
services
identify and
ainsi que
prioritize the
les
key causes of
comportementales.
service delivery
Et cela
challenges.
permet de mieux comprendre
This
comment les
helps
nouvelles
us
politiques
to
et
better
les contextes changeants
understand
peuvent
how new
influencer
policies and changing context are being interpreted at the facility level. The
Il
interpreter
s'agit
is
ici
very
de la
sorry, but the
combinaison
audio
des
of
entretiens
our
qualificatifs structurés,
speaker
les
is
observations et les
changing
examens
constantly.
de tous les documents. Next slide.
Next one, please.
Les principaux fondamentaux guident l'utilisation de l'outil pour s'assurer qu'il soutient
We
ce
have
qui est
core
déjà
principles and we want to make sure that it's supportive of what is already going on.
activité, mais pas
We are
plutôt
losing
aussi à
the
faciliter
audio
une
of
analyse
our
approfondie pour comprendre pourquoi
presenter were
les
very
choses
sorry.
ne se produisent pas.
So we
Next
try to
slide.
make sure that these concerning things are not happening again. Next one, please.
L'outil d'évaluation de l'offre de services et lutte contre le paludisme est fondé sur les comportements qui guident les
The
utilisateurs
Behavioral
à travers
Informed Malaria Service Delivery
il y
Assessment
a
Tool
4
guides
étapes.
us through 4 simple steps.
L'outil couvre les sujets liés
The
à
tools
la distribution des moustiquaires en
covers the
routine dans les
service
établissements
delivery
de soins,
topic related to
à
the health
l'évaluation de la
facility,
fièvre, au diagnostic du paludisme à travers les tests diagnostiques rapides, à la
malaria
prévention et le traitement du paludisme
diagnosis,
pendant la grossesse.
treatment, and malaria in
En
pregnancy.
premier temps, les données sont examinées pour
In the first step,
identifier
data are
les
reviewed to
difficultés
identify
auxquelles font face
facilities
les établissements de
with
soins.
ongoing malaria
C'est
service delivery
ainsi qu'on
challenges.
procède par un appel téléphonique
Then
effectué avec les responsables
we
des
continue with a
établissements de soins
phone call
pour
that is
discuter
done
sur
with
les
the person
problèmes
in charge of the
potentiels
selected
identifiés.
facilities to
Il peut s'agir
discuss
de
potential
la rupture des
explanation for
stocks.
this concern,
Il peut aussi
identify
s'agir aussi
and
de
determine
mauvaise
if
d'outils
if it's a
de
one-off
conseil.
challenge
Next slide.
or if it's an ongoing challenge that requires a visit. Next one,
Étape
please.
3, visite d'une
For
demi-journée
step
dans les
3,
structures.
we have the site
Et à
visit to
travers cette
identify
étape, il y a des
influencing
entretiens
factors.
avec les prestataires,
We have
combinés à
interviews
l'analyse
with the
des
provider,
des
combined
documents vraiment
with data
des
review
données de
and
la structure.
interviews.
Différents services, à travers cette analyse, sont
And
abordés.
thanks to
On peut
this
être au service
analysis,
opératoire, on peut être au service de gestion des données, on peut
we are
être au
able to
service
check
d'offre
the
de services.
data
Et on vérifie tous les éléments, tous les
and
outils de traçabilité, de collecte de données. Next slide.
we analyze all data that we have collected.
À
Next one,
l'appel
please.
de la visite sur
At
place,
the end of the site
l'outil
visit,
facilite le
the tool
processus de validation des
facilitates a
observations
process of
faites.
validating the
Les problèmes
observations made,
identifiés
the
ensemble
problems
avec les parties
identified,
prenantes,
and the
et
factors.
aussi aboutit
And
par la planification ou
it also
l'élaboration des plans de
creates a
redressement
solution generation and action planning.
tout en se rendant compte qu'il y aura des
We
problèmes qui vont
recognize the
mériter un
issues
autre niveau
and we
de mise
recognize
en
that some
œuvre
issues
ou
merit
d'application. Les
should get a
résultats sont
follow-up
partagés
beyond an
avec
individual
l'ensemble
facility.
du personnel de
These
l'établissement de soins
findings are shared
et
with the
puis
entire
avec
facility
toutes les
staff,
parties prenantes. C'est ainsi, on
and
peut
then
par exemple
we
dire
speak
les
about their
prestataires
lived experiences.
qui est alloué à la pharmacie ou bien à la
We
gestion
can
peut aussi
work
avoir
with
son plan
healthcare
d'action
workers,
pour adresser tous les
pharmacies.
problèmes
They are all
identifiés.
involved in developing
Après
an action
plusieurs
plan to
visites
address the
dans l'équipe,
challenges identified.
il y a un résumé qui est
There's
donné
also a summary
un feedback de tous
that
les
you can
problèmes
get
identifiés dans la structure.
with the feedback of all the issues identified in this facility. Next one, please.
Le programme national de lutte contre le paludisme souhaitait comprendre si les prestataires adhéraient aux directives du diagnostic,
We also wanted to
de la prise en
understand
charge de
whether
la
providers
fièvre
were
et
consistently
si ils
adhering
communiquaient aussi avec précision par
to
rapport
fever
à la rupture
diagnosis
des
and
stocks ou la
treatment
gestion des
guidelines
traces.
accurately and
D'autre part,
collecting and
on voulait
reporting
aussi
data.
chercher à identifier les
We
facteurs
also wanted to
comportementaux
identify the
qui
behavioral
empêchent les
factors
établissements de soins à respecter les directives
that
nationales.
prevent facilities to do
Le
these
PNP,
and
avec les
adhere
fichiers
to
de best practice,
these
a
national
examiné les données
policies.
sanitaires de
With support
tous
of the breakthrough action,
au
we're
cours
able,
d'une année.
the interpreter is very
Les
sorry, the
défis,
audio is
les
coming on
défis
and
ont
off.
été identifiés dans plusieurs domaines. Ça peut
We
être le
identified
cas
a
de la
couple of
prise en
issues
charge
in
du
different
paludisme
fields.
où les cas traités ne correspondent pas avec les cas suspects.
It was
La
on case
distribution des
management, confirmed
moustiquaires,
malaria cases exceeded the
le nombre
cases
de
tested
moustiquaires
positive.
dépasse le
It
nombre de
could be
femmes enceintes.
issues with the
Il y a eu à la
ITN
CPN1. Le
distribution. The
paludisme,
number of ITNs
pendant la
exceeded
grossesse,
the number of eligible
à la
clients.
place de la SP, on a
We had
choisi, on a
issues with
donné d'autres
malaria in
infos.
pregnancy,
Donc,
the
les
proportion
problèmes
of pregnant
identifiés
women having received
pouvaient
at
aussi
least a
concerner la
second,
rupture
third
des
dose
stocks.
of SP,
Les stocks
and then the
ne concordaient
stocks,
pas avec les
having
prises.
issues with stocks.
C'est ainsi, en 2023, un
We're
test
speaking
pilote a
about
été
shortages
réalisé.
here. So in April
La stratégie
2023, a
et
pilot
aussi
test was done,
ouvrir une discussion ouverte avant
and
d'établir les
we
liens
created an
entre les
open
postes
discussion
de travail des prestataires et
to
connaître aussi
speak
les
about
recommandations.
health facility workflow and refine the on-site process.
Next slide.
Next one, please.
Donc, chaque établissement avait sa taille, avait sa particularité. Maintenant,
Each
à travers les
facility
facteurs identifiés
was
étaient les
different in
mêmes.
terms of
Nous avons
size,
découvert
location,
les mêmes problèmes
but
liés à la
we
gestion des
had
plats,
the same
la gestion
issues,
de la
mismanagement of
liés aux problèmes de
uncomplicated and several
diagnostic de
severe cases of
mais
malaria,
aussi les problèmes de tenue
issues with
des données
stocks,
sanitaires.
inaccurate
Chaque visite a révélé les problèmes
documentation,
similaires dans
and
toutes les
each visit
structures
showed or revealed similarities and
Next slide.
differences as which factors were preventing
Leçon apprise,
high
donc,
quality malaria service.
structurée de la qualité de l'outil a
The
permis de
open-ended
comprendre
structure
aussi avec compréhension
was
approfondie les
helpful
processus de
because we were
fabrication,
able to
l'environnement
understand
du
deeply
travail et
the
la
clinical
dynamique de l'équipe.
processes
Cela a permis de révéler que les
and the
goulets
workplace
d'encadrement,
environment.
avec une approche multisectorielle,
This
multidisciplinaire, on
was
pouvait comprendre
helpful
les facteurs qui empêchent le bon déroulement des activités. Donc, l'exploration
to
quantitative et
understand the
qualitative a permis
multisectoral
d'expliquer
impact
pourquoi certaines
that
actions
issues can have.
ne sont pas prises en compte et qui empêchent aussi le bon déroulement des interventions dans les structures. Donc, l'expérience de la RDC montre que l'outil
From this
pouvait être
experience, the experience of the
facilité avec
DRC,
utilisé dans d'autres
it
outils
shows that the
parce qu'il
tools can be
permet de
effectively
résoudre
implemented
les
without
explications
burdening
qualitatives
users
que
and
les outils
providers.
quantitatifs n'arrivaient pas à ressortir. Donc, l'examen des registres pouvait apparaître très
The
long au
process
cours de la
created a safe
journée,
space for providers
mais le projet
and
pilote a
helped
démontré
us
que cela
understand the
pouvait être
importance
rapidement
of
fait
qualitative
et
data.
ressortir
We had
l'écart
this open
entre les
discussion
données
that was very
rapportées
helpful,
et les données qui ont été
and we were
prises en
able to
compte dans
use
les
data
structures.
and provide all the providers'
Next slide.
interviews with the results. Next one, please.
Donc, le projet pilote a révélé que l'outil permet une compréhension plus nuancée des causes
The
sous-jacentes.
project revealed that the tool allows for the interpreter. Sorry, we lost our speaker.
Tenant compte de tous les facteurs structurels, cela nous permet
Okay.
aussi
We were
de
able
comprendre les
to
motivations
consider
et
not
les
only the
contextes
structural
qui ont
factors, but
empêché
also
les
the behavioral
prestataires
aspects.
à bien œuvrer, à bien respecter la politique nationale.
And
Et
we're
nous
able to
souhaitons
respect
remercier
national
toutes les
policy.
personnes répertoriées ici dans cette dia qui ont concouru au niveau du programme national de lutte contre le paludisme, au niveau de l'USAID et au niveau des Breakthrough Action. Merci.
And this is what we did at the DRC and at Breakthrough Action. Thank you.
Wonderful. Thank you so much, Augustin, for sharing how SBC strategies can reveal root causes and actionable solutions in malaria service delivery. Your insights demonstrate the power of combining data with collaborative problem solving to create meaningful, sustainable change. And now we'd love to hear your questions or reflections. Please type them into the Q&A and we will get to as many as possible. I know that we already have a few questions, so while people are perhaps adding more, we will start. The question for Juliet, please. Question was, in discussing the package of interventions, an attendee had said that this looks amazing. Can you please talk more about the compassion champion aspect and potential challenges or pitfalls to watch out for? Thank you. So Juliet, to you.
Okay, thank you very much for the question. The champion was selected according to the when we start, we introduce the suggestion form, which client are able to fill on what they perceive the service provided at that particular day or at that particular visit. So client were supposed to, provider, they are supposed to provide the form to clients at the end of the visit. Then the client is filling on what they see the service received. There is a 4 question with 3 answers. Those answers, they are in green, yellow, and red. Then after the end of the month, all providers of that clinic are set together and open that suggestion box, and then they're just counting the greens one. If certain provider get more green suggestion, that is the champion of the month. The challenge which was observed during our study, it was sometimes providers who are allocated at the registration entry point, they have many green compared to those who have specific session. For example, we deal with postnatal mothers. For example, when the client come to the clinic, they are supposed to start at station X. So all client will go at that station, and fewer will go to vaccination, fewer will go for weighing, fewer will go for treatment. So obvious, you can find the provider who sit at the registration will have more greens compared to others. That was the challenge, but we solve it and we select a champion according to the station so that we can be fair. Thank you. Back to you, Stephanie.
Thank you, Juliet. We'll move quickly to Augustin, a question for you, and I hope that the audio will work for you and for our listeners. Were providers open to hearing the feedback from the team at the end of the health facility site visits?
Yes. Yes. Providers are very open to hear that. Because with this feedback, if they do not hear this feedback, their clients will go to another provider. And the resources will not be used and the community can boycott them. So it's very important for the provider to be able to hear this feedback, to be able to improve their service.
Thank you so much. All right, trying to move the questions around each of our presenters or groups of presenters. Heather, a question for you. Could you please share any other examples of how the provider behavior ecosystem has been applied in other country settings? So we heard about how it was applied to respectful care in Tanzania. Do you have other examples you could share?
Yeah, thanks, Stephanie. One thing I would like to mention is that the provider behavior ecosystem map is intended as a thinking tool. So it's kind of that first step of really thinking through and looking at all of the factors that may be influencing. But as a practical tool, we also developed an accompanying tool called the Provider Behavior Change Toolkit. And this toolkit allows people to really start digging in and understanding what are the factors that influence provider behavior in my particular context with the group of providers that I'm working with? And how do I prioritize the ones that are the most influential? And then how do I develop solutions together with the providers and clients and community members to address those factors that I prioritized? And so it is meant to be both a thinking process and then also a more practical applied process as well. But a couple of different examples of just the ecosystem map being applied in different countries beyond Tanzania. It was used by the Momentum Safe Surgery in Family Planning and Obstetrics project in India. And they use it as part of their human-centered design process to start to identify the various interconnected factors that were influencing interpersonal communication behaviors among providers. And then they also used it as a framework to then start developing a couple of different tools that would help them with addressing some of those factors and emergency obstetric care. And so it was really twofold there. They used it to start thinking about the factors and then also as that framework piece to then think about how do we develop some of those tools that are needed then. And then another way that it was used in a different set of countries was with the West Africa Breakthrough Action Team. And they used it to categorize a lot of research that they did. They did interviews and talked with people in different countries to understand the situation with providers. And then they used the ecosystem map to categorize their findings so that they could understand, okay, this is where we're really seeing a lot of the issues. And then with each of the governments and stakeholders in the different countries, they were able to identify where are the areas that we really want to focus in on so that we can address some of the issues that we found through our research. So those are a couple of different examples. And I will mention that we are putting together a web page that will be available in the next few months that details out all the different ways that the provider behavior ecosystem map has been used in different countries, as well as the provider behavior change toolkit that I mentioned, which are both available on the link that was shared earlier.
Wonderful. Thank you, Heather. The next question is for Dr. Sunday. So, has the Ministry of Health in Tanzania decided how best to use these findings? Person mentioned they saw that the study was done in faith-based facilities. Will you also apply it to public sector sites?
Thank you very much. The Ministry of Health has really been working on improving experience of care through different initiatives, including this partnership with USAID Uzazi Star project. And we remain keenly interested on the findings. As you heard, this is preliminary, and hopefully we get to have the final results. And the next step, of course, will be to share these results with the hierarchy at the ministry and be able to incorporate the findings in your subsequent guidelines, as well as treatment protocols, so that it can improve the work that we do here. So we really look forward to the findings once they are completed, and the dissemination will be a key point to help this influence our policies around the experience of care. Thank you.
Thank you, Dr. Sunday. Heather, there is another question for you, which would be, how does one handle the complexity of the provider behavior ecosystem?
Come up
We'll see.
again.
Oh, pardon, Dr. Sunday.
Yes.
Thank you for your answer. This question was for Heather and her presentation on the provider behavior ecosystem.
Okay, thank you.
Thank you.
You will see me smiling, because I think the first step here is that we do have to acknowledge that the provider behavior ecosystem map is complex. But I think that gives us an important moment to pause and reflect and say, wow, there are so many factors that influence provider behavior. And it's really important for us to recognize those and not do simple strategies where we just, trained providers. We really do need to think about this in a systemic way, and systems are complex. And so the map reflects that complexity. However, we don't want to get stuck on the complexity part of it. We do need to start breaking it down. And part of the process of doing that is something that I mentioned previously in my response, which is using the provider behavior change toolkit to really start to dig in and understand what are those factors. And I will say it does take time. You need to take some time to explore those factors and really think about how those factors are influencing provider behavior. But another piece of it that I think is really critical is to remember that because we are taking a systems approach, that means that no single project or organization is going to be able to address these factors. It does need to be a partnership opportunity. And so we need to think about, how do we address these different factors across the ecosystem by having those important partnerships and figuring out who needs to do what. Maybe certain projects are better structured to address a given set of factors, and another project or organization is better placed to address another set of factors. And so as you start to look at that, really thinking about those partnerships and how you can approach it. And I think the other piece is to also take it in stages. Of course, there are so many factors that could be addressed, but that process of identifying and then prioritizing the factors is really critical. We have to think about what's the most important thing for us to address now, keeping in mind the different interconnections there that we may want to consider, but it may need to be a multi-stage process in addition to inviting other partners to address it. Thank you.
Thanks so much, Heather. So we've come to the end of the time that we have for Q&A. Thank you to all of the presenters for the really thoughtful responses. Thank you to our attendees for their thoughtful questions. A few that we did not get to addressing right here have been addressed, I understand, through the Q&A feature. So as we wrap up, I want to thank all of our presenters for sharing such impactful examples of SBC's roles, its role in strengthening health systems, From tools like the Provider Behavior Ecosystem Map to compassion-centered care and behaviorally informed service delivery approaches, today's session has highlighted how SBC can address systemic challenges and improve health outcomes at all levels. So thank you for participating. Before leaving, please complete the short poll that has popped up to help us improve future sessions. And we look forward to seeing you hopefully at our next webinar, which is Advancing Gender Equality and Social Inclusion, which will take place on January 8th at 8 a.m. Eastern Standard Time. We'll start promoting that webinar after the new year. So until then, please take care and thank you again for joining us.